Right now, without further ado, I'm really pleased to introduce Professor Clyde Hertzman. Dr. Hertzman is a professor here in the School of Population and Public Health, and he's also the director and founder of the Human Early Learning Partnership. Clyde is also, I would say, one of the founders of our understanding of the social determinants of health. If you know anything about the social determinants of health, I'm sure you've come across Clyde Hertzman's name. And last year, he was named Canada's Health Researcher of the Year. So this is a really great opportunity for all of us to get a very rapid-fire overview of population health and the social determinants of population-level health. And I hope that you find this introductory lecture very sort of reorienting to the idea of thinking at the population level. And Clyde uses a lot of examples from the early part of the Lifecourse. And I think that that's something all of us can sort of identify and relate to. So welcome, Clyde. Thank you again for making time in your extremely busy agenda for this. I'm going to move so I can see you.
Okay.
And take it away.
Okay. Yes. Well, it's great to be here. And it's great to see this class growing. Each year that we've done this, it's got a little bit bigger. And I understand that many of you are SPPH students, but many of you are from programs around the campus. As Jeannie says, I'm going to do some introductory stuff about population health and the social determinants of health, but I'm really going to focus a lot on the early stages of human development and how they fit in as one important exemplar, partly because that's, where my strengths are. And I think throughout this course, you will end up seeing lots of material presented about work and about aging and about other elements of this. But I'm going to approach this to begin with from the standpoint of where we came from, in a sense, inventing the concept of population health. I mean, the notion of population health is used internationally, but it grew out of work that was done here in Canada, looking at information on social patterning in health. And so I'm going to start with some of that and then move on from that. So, place I'm going to start is with a thing known as the Whitehall Study. The Whitehall Study was a study of British civil servants that was done in the 70s and the 80s and into the 90s, and it continues to this day, actually, where they identified British civil servants who all were being paid a living wage, who are all fully covered with medical coverage of one sort or another, and track their mortality and their morbidity, and in this case we'll talk about their mortality, over time, over a number of years, right? So this is basically a longitudinal follow-up study. For those of you who have done some of your methods courses, you'll understand about that. The key thing that came out of this study was that the cumulative mortality, cumulative death rates, of the members of the British Civil Service followed patterns that followed their social class status within the civil service. So over a 10-year period of time, the cumulative level of mortality for those in the administrative grades, which would be the Cambridge, Oxford trained type people, was cumulatively lower than the professional and executive grades, which would be like the program managers and people like that, which was cumulatively lower than the clerical people, which was in turn cumulatively lower than the people who are engaged in blue-collar occupations, such as maintenance jobs in the building and stuff like that. So what you had, and you're going to be hearing this term a lot, I'm sure, in the course of this course, is a gradient. That is to say, even though we're dealing with people here with living wages and full medical coverage, you're seeing, as you go from the most to the least privileged group within this, you're gradually seeing an increase in the level of mortality. So it's a gradient. It's like a gradual kind of stepwise function up, right? Now, Before the Whitehall study came out, there was a lot of stuff out there that suggested that there were socioeconomic patterns like this in wealthy societies, gradient patterns. But many of them could be dismissed based on the idea of people getting sick and then becoming poor, or various other kinds of selection factors. But with the Whitehall study and the generation of studies that came along with it, even the most skeptical people began to recognize that in wealthy countries, post-scarcity countries, in populations where absolute material limitations to life were not a factor, that nonetheless we were seeing these gradient patterns in mortality and in morbidity based on, in effect, socioeconomic status within the population. Moreover, if you started breaking it down into specific diseases, and here's heart disease mortality, the immediate direction thinking would be to say, well, it's got to be about lifestyle choices, right? That it's got to be that as you go down the socioeconomic spectrum, people are engaged in more unhealthy behaviors, et cetera, et cetera. And to a certain extent, that's true. But this slide was a very important one out of this family of studies, because what it showed is that when you looked at the relative mortality for heart disease, for which we have a bunch of epidemiologically demonstrable risk factors, and you factored them out, which are in these kind of cross-hatched and lined bars and all the rest of it, you can see that they explain some of this fourfold difference in mortality, which is based on that. But the majority of it isn't explained by those factors. In other words, it seems to be embedded in social status per se, right? And so that becomes a very, very important result. That, along with a lot of other information, is suggesting that, in fact, the social environment is, in wealthy countries as well as in poor countries, getting under the skin and influencing health status above and beyond ways that can be explained by disease-specific risk factors. So if what you do then is go to the sum and substance of the world's literature on the emergence of these gradients, you see a number of patterns that are rather interesting. First off, gradients are ubiquitous both in wealthy and in majority world countries, whether you divide the population up by income, education, or occupation. So in other words, you can say, take Canada or take Chile and divide it by the richest 1/5, the next 1/5, the middle 5th, the next 5th, and the poorest 5th of income, and you'll find a gradient. You can throw that out. You can go with university graduates, some college and university, high school graduation only, less than high school, you get a gradient. You can take something like the Blishen scale of occupational status in a country like Canada and, divide occupations from the lowest status to the highest status. You get the gradient, right? So it is a robust finding, right? It emerges over and over again, and it emerges both in majority world countries where you get the mixture of clear material limitations to health, and not enough food, etc., and in the wealthy countries as well. So that's a really important point. The second point, and this is something that has made the whole study of the social determinants of health a very interesting and important complement, but also a challenge to traditional ways of thinking about health, public health, and biomedicine, is that gradients seem to cut across a wide range of disease processes. So I showed you overall mortality and heart disease for the British Civil Service, but I could have showed you a variety of cancers, I could have shown you behavioral-related conditions, I could have shown you a lot of things. And in the end, one tends to see these gradients for virtually all conditions with the exception of malignant melanoma and some of the gynecological cancers, right? Some of the gradients are steeper than others, like lung cancer has a steeper gradient than, let's say, some of the arthritic kind of processes. But virtually all diseases show socioeconomic gradients in expression. And so when you start to try to understand that and factor out the possibility that there is a selection trick going on and say, look, that this is, in fact, something about the social influencing health status, then that requires different ways of thinking about biology and pathology than you usually think about it. It doesn't mean building it up disease by disease. It means trying to understand processes whereby vitality and its opposite can be engendered in some broader way, right? So it frames a different way of looking at human biology. And we're going to come back to that because I've got some things to say about that here. Third, as I pointed out before, even though many traditional risk factors, behavioral, lifestyle things, do themselves have socioeconomic gradients, smoking, etc., nonetheless, by and large, socioeconomic gradients in health status, most of the relative force of them, are not explained by those traditional risk factors. So that you can say part of the equation would be how do we change socioeconomic differences in response to health promotion messages that are individualized. But there is a whole question that goes way, way beyond that, right? And, that's a very, very important part of this equation. Another thing that's interesting is that the gradient, and this goes along with the second point, is that the problems that cause morbidity and mortality in our society have been changing, and they've been changing fairly rapidly. If you go back 100 years ago, principal causes of death and disease were, by and large, infectious diseases like tuberculosis, right? Then in the middle part of the 20th century, there was a rise of heart disease as a major cause, which has actually been gradually on the wane over the last 30-some-odd years. It's still really important, but it's been on the wane. And, in effect, many of the cancers, which have not declined in their force of mortality and morbidity, have remained pretty high. And at the same time, we've had the rise, at least in terms of reports, of morbidity from mental health problems in ways that were not discussed before, right? And we don't have good enough data to really say exactly what the patterns have been. But the point is that if you go back 100 years ago in countries like Britain where you can do this, and you can look at socioeconomic gradients in mortality, they loaded on the popular diseases of the day. That is to say, tuberculosis and infectious diseases, right? Then, between World War I and World War II, heart disease starts to become endemic in society. And it comes in, initially, as a disease of those who were privileged enough to live long enough to get it. So early on, back in the 1920s, let's say, the image of heart disease being a disease of, wealthy people living degenerate lifestyles or something like that, that had some validity, right? But by the 1950s or so, the gradient pattern had set itself up. So these days, the notion of heart disease being the disease of the stressed executive is nonsense. Heart disease is the disease of the stressed waitress, right? Is what we know, right? So that the gradient reestablished itself. And in our time, the same thing has happened with HIV/AIDS, where it comes into society, a disease of those who have specific risk factors, but within about 20 years or so, it forms the gradient pattern, right? Another very, very interesting conundrum that doesn't fit traditional notions of biomedicine or public health occurs among males and females. Early on, when we were doing work on gradients, there was a lot of talk about how gradients were male, not female, right? And that was largely because people were looking at them only in terms of mortality, right? And so when you look in Canada and you look at gradients in mortality by male income or male occupation, they are steeper than they are for women by income or occupation. However, when you go beyond that and you bring in morbidity, it changes. So for men, gradients tend to load on the things that kill you. For women, gradients tend to load on things that make you sick, but don't necessarily kill you. So if you look in Canada at quality-adjusted type life years, And you, in various of your courses, will come across these kind of measures, healthy adjusted life expectancy. The steepness of the gradient for men and for women in Canada is just about the same. Right? It's just that for women it loads on morbidity, for men it loads on mortality. So if you integrate them, you get similar size gradients. And I mean, that's rather interesting because generally speaking, the difference in health status between men and women is driven by the fact that men get things that kill you and women get things that make you sick and don't kill you to a greater extent. I mean, so it's that difference is nearly enough to explain male-female health status patterns. So it's interesting that for men and for women, these things load on the things that they're most sensitive to in that sense. Now this next point, flattens up. This is the point, in a certain way, that makes using the gradient as a way to open up the issue of social determinants of health a useful thing. And what I mean by gradient flattens up is that in countries which have a relatively flat socioeconomic gradient in health, that is to say, when you go from the top to the bottom of the socioeconomic spectrum, that the relative differences in health status are relatively small, those countries' average health status tends to be better than those who have steep gradients, right? So, for instance, and it's not easy to do this, right? Because comparing socioeconomic status positions across countries is mined with methodological difficulties. And the international data collection in relation to this is really based on country-specific studies, right? So we do not have, despite things like Gapminder that you'll find off the web and all the rest of it, we do not really have something equivalent to the way in which, the OECD measures gross domestic product in a strictly comparable way. So the number of studies that actually allows you to say, comparing socioeconomic status measured in exactly the same way in different countries and taking into account all the methodological problems, what's going on, you don't see that too much. But having said that, it is true that countries like the UK and US in particular that have relatively steep gradients tend to have the lowest health status among the wealthy countries. And countries like the Scandinavian countries, which tend to have the flattest gradients, tend to have the highest health status among the countries. And so when you look at a correlation between health status and expenditure on healthcare, there's no relationship there. But when you look at health status among the wealthy countries and steepness of gradient, there is, right? Now, as you go through this work, you're going to see, I think, the work of Richard Wilkinson as you're going through, right? Richard Wilkinson is famous for dealing with inequities and equity and health, one way or another. What I want you to keep in mind when you read his work is that what he is talking about is something slightly different from what I'm talking about here. So I'm talking about the idea of a health gradient according to socioeconomic status being steep or being flattened. And when it flattens in a positive direction. What he's talking about is the level of inequity in income in a society and the impact it has on average health, on levels of criminality, on school achievement, etc., etc. So if you listen to that really closely, I'm talking about gradients in health according to standard socioeconomic categories. He's talking about the degree of socioeconomic inequality and what it does to the average health status of the society. Okay? Now, that distinction right now might be difficult and puzzling for you to grasp, but by the end of this course, you'll understand it. Okay? And they're really important because they are different kinds of arguments that require looking at data in different ways, right? So there's a lot of, unfolding of this particular onion that comes up as a result of that. Now, the final point here, and this is really the takeoff point for the rest of this lecture, is that, and this is very much a Canadian contribution as well, is that when you look at it from a Lifecourse perspective, what you see is that gradients in health begin life at the beginning as gradients in what I'm going to call developmental health. In other words, the state of physical, social, emotional, language, and cognitive development early on in life. That might sound a commonplace given all the things that we've said up until now, but it isn't. And when that was recognized, it really, really changed the game and changed the nature of the way in which we need to look at human experience and how human experience influences health. Right? For example, if what you do is you simply use traditional methods of thinking about health status using disease categories, what you will see is that there is a gradient in relation to infant mortality, which one could attribute to parents' conditions. And then, between, let's say, about age 5 and late teenage, that gradient in disease process traditionally defined sort of disappears and then reemerges in midlife, right? And that gave rise to a whole lot of ideas about, well, there's selection factors going on here, et cetera, et cetera. However, if instead of doing it that way, you look at development, measures of development, and we're going to spend lots of time talking about that, it turns out that the gradient is pretty much continuous from as early as you can measure the state of developmental health. And so what I mean by that is this. If, let's say, you look at what's going on in the early years of life, there are a whole series of sensitive periods in brain and biological development. And of course, between 0, and I'm not going to get into the abortion debate about whether fetuses are life or not. So 0 is whatever you imagine it to be. Through to school age, what you can see is that that's the time where, in a sense, there's the densest network of sensitive periods in brain development. And what's going on during that period of time is the brain is, as they say, sculpting itself according to the qualities of experience that it has. And sculpting means that certain brain cell to brain cell connections are being reinforced and other ones are dying away, right? Neurons that fire together, wire together, all of that sort of thing. And it occurs in a kind of a hierarchical way. As this thing was unfolding, you will have noticed, for instance, that the vision curve in white came out first, right? So what's going on then is right at the time of birth, child can actually focus at about 13 inches from them, which is a good sort of face to breast distance, right? And what the neural circuitry is predisposed to want to try and do at that point is to pick up a consistent set of human faces and start to be able to wire up vision to the deep affiliative structures in the brain, the amygdala, the locus coeruleus, so that understandings of belonging and not belonging can start to emerge. So there you get your basic imprinting. I am the same species as this other person. When the face is upturned, that means I feel good. When the face is downturned, that means I don't feel good. Those are the kind of things that are wiring up at that point, right? And we already know from studies of, deprivation in orphanages and other children who are subject to neglect in the first couple of years of life, that if those things don't build up, then what you end up with is a developmental pathway that has got to do with being overly independent early on, but as time goes on, the non-attendance to human face and the non-ability to use the human face as a point of socialization creates all sorts of risks, from sociopathy to taking the proverbial ice cream cone from the strange man and all of that stuff, right? And so those things are occurring very early that way. Similarly, by about age 3 or so, children who have grown up in environments where there's a lot of anger will, if you put, evoked response potential hat on their head and you show them a series of adult faces from very happy to very angry, will react with fear to faces that to the rest of us don't look threatening, right? So they they wire up in a way that shifts their threshold for detecting fear, right? So ambiguity becomes a threat to them, right? And so in the same space and time that you and I might be, these people are in a different world because the world is neurobiologically more threatening for them. Language. During sensitive periods in language development, children's language, in terms of understanding words, receptive vocabulary, and expressive vocabulary, on average, goes up as a straight dose response with the number of words they hear per unit time. So a few years ago, after sticking microphones inside of people's houses and counting up the number of words that were being spoken to the kids, a paper was published called the 30 million word gap that showed that, in fact, when you compare the child in the U.S. who'd heard the most language spoken to them versus the least language by the time they reached school age, you're talking about a cumulative difference of 30 million words. And in fact, in these studies done by Risley and Hart and other groups, Huttenlocher and so forth, that you will see if you get into the literature on this, that you can show that as you go from the kids who hear the least language to the kids who hear the most language, the number of words that they understand and can express goes up as a straight dose response with the number of words, so that their language facility diverges over time as cumulative exposure diverges. And, for better or for worse, all things being equal, those differences in language exposure tend to follow level of education of parents, right? So what we're talking about here is something that is very prosaic. It's about cumulative differences in small ways on a day-to-day basis, right? The child who has read bedtime stories versus the child who has not, right? Regularly, right? The child where the parent gets down at eye level and talks to the child versus the one that's not. It's that we're not talking about out-and-out abuse and neglect in this case. We're talking about the cumulative effect on developmental trajectories of small day-to-day differences, right? And this is really, really important because when you try to understand social determinants of health, you can't avoid the idea of the epidemiology of daily life. And that's a lot of what this is about. There's the dramatic. Clearly there's the dramatic. And when I talked about, the vision system and what it means to be neglected, there are the dramatic stories, but there's also the prosaic, right? So they both have to be kept in mind. And so it goes, I could tell you other stories about developing, self-regulation and so forth. The point is that by the time kids reach school age, there has been differential qualities of early experience that kids have had in the places where they're growing up, living, and learning, be it at home or be it in care environments. And that those things have tended to form a gradient. So that in Canada, if you put together a multi-attribute index of physical, social, emotional, language, and cognitive development, and that you ask about vulnerability, and you just look at it in terms of quartiles, let's say, of parental income, there's our friend the gradient there by the time kids reach transition to school, right? You can see a gradient from about 14% of the kids vulnerable to about 32% of the kids vulnerable in one of those main broad domains of development, which are sensitive to early experience and, incidentally, are what are recognized as evolving capacities in the Convention on the Rights of the Child, which is important because Canada is actually a duty bearer to provide kids with environments that allow their capacities to evolve, and we can think about whether or not we're fulfilling our commitments to that. So anyway, that's what emerges. And then what starts to happen is that this notion of gradients flattening up starts to play out, right? So if you move forward, and here we're talking about development of skills necessary for later on life. So numeracy skills here, right? These are the international, one of these international math tests that this is based on, right? And what we can see here is how kids did in different countries in relation to their parents' level of education. So these are gradients, right? And in this case, because the outcome was, because of the way the study was set up, we could do a direct comparison to look at the relationship between steepness of gradients and how kids did on average. So to give you an idea on this, a level 4 would mean you could teach math in university. A level 3 means you have all the math of daily living. A level 1 means you know that 10 is a larger number than 5, but not an awful lot else, right? And what you can see here is every country's got a gradient going from parents' lowest education to highest education, but they're different steepnesses, right? So down here with Britain and New Zealand and some of these other countries, including the US, they're relatively steep, going down into the on average level 1 at the bottom here. And then they get shallower with Canada sort of in the middle, like it quite often is. And then Sweden there, where there is a gradient, but as you can see, that even the children of the least educated parents are still averaging out in the level 3, right? So overall, if you sort of imagine where the median is of each of these graphs, you can see that this is a gradient flattening up situation, right? So there is socioeconomic inequality everywhere, but where it has been buffered is what makes the differences. So in other words, the differences are not so much in how the children of the most privileged groups do, that the differences gradually get larger as you go down, and that's what matters the most. So this pattern sets itself up, and it raises then questions of what are some of these countries doing to deliver more equity than other countries, right? And you can see that that can have a lot of different advantages. And it's interesting because at this point, of the world's 6 most, quote, economically productive societies, using traditional measures of that, 4 out of 6 of them are the Nordic countries, right? So despite all of the baffle-gab we are always hearing about being taxed to death and so forth, those systems seem to deliver relative equity, and relative equity not only in health, but in developmental outcomes like this that then end up contributing to way in which the economy can be flexible in the modern time. So it all ties together in that kind of way. Now, having said that then, if you look at studies that begin at birth and follow populations 2, 3, 4, 5, 6, 7 decades throughout life, you can see that early life, the experiences in early life, and the state of development in early life has a statistically independent contribution to health problems later on in life, even after you take into account the things that occur later on. Which is not to say that the things that occur later on don't matter. But what I'm saying is that these things contribute notwithstanding what comes afterwards, right? So when you think about early experiences and early physical, social, emotional, language, cognitive development, by the end of the second decade of life, they have independently contributed to things like risk of school failure, unwanted teenage pregnancy, early criminality, right? By the third and fourth decades of life, you see independent contributions to obesity, elevated blood pressure, depression, and other mental health problems. By the fifth and sixth decades of life, you see contributions to things like heart disease, diabetes, and other chronic diseases. And I'm just about at the end of my 6th decade, right? So I keep promising myself every time I see this, I'm going to change this slide. Anyway, to older age, you see independent contributions to premature aging in a variety of different ways, and rates of memory loss. Okay? Which is probably why I never changed the slide, because I'm having... Anyway, you get the point, right? And you know, in fact, this work, right, I mean, we're in the harvest period now because some countries, unfortunately not Canada, but particularly the UK and New Zealand, put in place birth cohort studies decades ago. And these things are being harvested now. So for those of you who ever have seen those movies, 7 Up, 28 Up, those ones, right? At the same time that they filmed those 13 kids, they impaneled all 17,000 kids who were born in the first week of March 1958. And have been following them ever since, right? So I work on that study, and some of this comes out of this. But they also had a study in 1946 and another one in 1970 and a millennium cohort. And if you go to London, all of these studies are organized now so you can work on them together and you can do inter-cohort comparisons of all sorts of things. So some of it's about health, but some of it's about, like, you know, women's earnings trajectories and how they compare between cohorts and all the rest of it, right? So it's a marvelous system, right? And there are even studies then that go back into the 1920s, one from Sweden, and in the interwar period, the Roundtree cohort from the 30s, which really does allow us to follow people into old age. So when we say these things then, this is based on Lifecourse epidemiology, where, you know, things are factored out later on. In my particular work, part of the thing that got me moving on this was we looked at the simple measure of self-rated health at age 33 on the British birth cohort study. So this is the simple question of, compared to others of your age and sex, would you say your health is excellent, very good, good, fair, or poor? Well, so what? You know, people go to school for 15 years, learn how to diagnose things, and you ask a stupid question like that. Turns out that stupid question is very predictive, right? People who say fair or poor are 4 times as likely to die in the next 10 years than people who say excellent or very good. So if anybody ever walks up to you and asks you that question, whatever you're feeling, you say excellent or very good, right? The point is then that was a prevalent predictor of later health status. And what we found using the 58 cohort was that when you factored out everything after school entry, 3 variables from the 0 to 7 period independently had a predictive value on self-rated health. And they were, 1, whether or not the child was read to consistently early on in life, which was a variable we had. 2, in the opinion of the first teacher they met, who was interviewed as part of the 58 cohort, were they having an easy or difficult time adjusting to school socially and emotionally? And 3, with our ultimate knowledge of what their adult height was, what fraction of it had they reached by age 7? In other words, was it relatively close or relatively not? Not at age 11 or any other age, at age 7, because there's an early burst there. So it was about whether or not they had the early burst or not, which is partly under stress control, it's partly under growth hormone control through stress, right? So if you were read to consistently, adjusted easily into school, and growing relatively rapidly as a proportion of your adult height, you were only 1/5 as likely to be in a state of fair or poor self-rated health by age 33 than if you were the opposite of those 3, after taking into account everything that came afterwards, right? So a very impressive, I think, result that points with the reading variable at the language and cognitive environment, the social adjustment variable at the social emotional, and the growth at the physical, right? So the notion that those experiences and the developments that they index then can have a life course contribution, I think there's the evidence on that is pretty strong. Now, where this is all going then is in 2 different directions. One is, for me now to show you some of the kind of things that we try to do, having identified early child development and its determinants as being a very important part of the equation of social determinants of health, how we understand that at the level of the population, and some of what we're trying to do to get this to be built in to the social rule book in a society like Canada. And then I would like to go back and spend some time understanding the developmental biology of the gradient a little bit. So we're going to go in one direction and then quit and then go in the other direction, okay? And then hopefully by the end of this, you will be confused and excited. Not just confused. So first thing, early development instrument. We have a made-in-Canada tool called the Early Development Instrument that is designed to collect population-based data on the state of children's development. So this is a questionnaire type thing that is filled out by kindergarten teachers when they know their children for several months. So we usually do it in February of given school year, right? It has 104 items on it. Only takes the teachers about 15, 20 minutes to fill out. So we buy them out of the day of their time and they do all their kids, right? What does it measure? It's got items on physical health and well-being that the teacher's in a position to know about. So small muscle coordination, large muscle coordination, whether the kids are coming to school hungry and tired, things like that. Right? Communication skills has got to do with whether or not the kids can understand and be effectively understood in the language of instruction of the class. When the scale was originally created, we thought of this as being primarily about English as a second language, but that was before all this stuff on, kids' language going up as a straight dose response with the exposures in growing up came out. And sure enough, you see risks where ESL is a big issue, but there are lots of parts of this province where there's no ESL, and there's a lot of kids who do not understand and cannot express themselves effectively in English because their language exposure has been so limited in the first 5 years of their lives, right? The language and cognitive scale, on the other hand, is traditional readiness for school. So this is, do you know your way around a picture book? Do you know some number facts? Do you know some letter facts? Those kind of things at a level appropriate for kindergarten. The emotional scale is about how kids relate to each other as peers. Are they physically aggressive to each other? Are they, quote, relationally aggressive? In other words, do they form little gangs and cliques? Or are they empathic and helpful to each other, right? So it's based on questions like that. And the social scale is about how kids function in the semi-formal environment of the kindergarten class. So this is, can they pay attention? Can they cooperate? Can they, are they disruptive, et cetera, right? Those kind of things. So 104 items. each of these scales, the teacher simply answer questions that are, does the child do such and such some of the time, all the time, never, that kind of thing. So they're not directly rating the kids, they're observing the kids, and then these are bundled up into scales. And for each scale goes 0 to 10, and for each of those scales we have a number between 0 and 10, which is our vulnerability cutoff, where below it is said that the child is behind where we'd like them to be on that scale. Right? So as you can imagine, if we have enough money to buy kindergarten teachers out of the day of their time, we can get population-based data, and that's what we've been doing. We started this in Canada, and now it's spread to Australia and 13 other countries. So we include all children. And what we do is we take their postal code, the individual child's postal code, and we bookkeep them in the neighborhood they live in. The reason we do that is because this is not a test of the school, right? This is about the state of children's development, and the kindergarten teachers are our developmental sentinels because they see the kids, right? And what we're interested in is this giving us, at first, a backwards look. In other words, the state of children's development speaks to the quality of environments and experiences they've had up until that time. Where have they had them? They've had them in families that are situated in neighborhoods. So, notwithstanding residential transiency, the 6-digit postal code allowing you to put kids into residential neighborhoods is the least bad way to do this. And in fact, we worked across the province to divide the province into over 450 neighborhoods for analysis. And then what we do is we nest the neighborhoods in the geographic school districts. And I'm emphasizing geographic. BC is divided into 59 geographic school districts. So you are book kept in the school district where you live, regardless of whether you go to the public school or an independent school or a band-run school or whatever. You're book kept where you live by school district. So we use it as a geographic unit, right? And then that goes to the province. And so that allows us to generate maps like this. You notice this map here, then, is the provincial map divided into the 59 geographic school districts. 57 out of 59 are represented on this map. Stikine is suppressed because even though it's geographically the largest in the province, there are less than 35 kindergarten children in the wave, which is our suppression rule for reporting. And Abbotsford, even though we have data in the past for Abbotsford, notwithstanding the school strike that's about to happen now, the school board and the teachers are so much at loggerheads these days that they can't agree on doing the EDI. But all the other school districts are in, right? And so we've been doing this. And you notice it says wave 4. We've done 4 complete waves of the province over the last 10 years of this, right? So we've gone back to the school districts, some on an annual basis, some every other year, et cetera, in order to collect the data. And what this shows then is the fraction of children who are vulnerable on one or more of those 5 scales of the EDI that I showed you. So vulnerable on one or more scales is to children's development what infant mortality is to infant mortality, right? It's sort of like, it's like the one summary statistic that you can slap down on the table for public policy discussions that's easy to understand. So a lot of work has gone into coming up with something that's valid like this. And so we have across the province one school district in this latest wave where less than about 16% of the kids were vulnerable on one or more scales of the EDI. Several, you can see out here and over here and there, that were in the 17 to 23 range. Another bunch that were 24 to 28, light red color 29 to 34, and the reddish color 35 and above, 35% and above. This is at the level of the school district now, where you're averaging across neighborhoods that have socioeconomic differences, right? And yet what you're seeing there is we have one district that's actually sitting at about 10%, about 7 that are below 25%, and 5 that are above 40%, right? So a wide range when you look at it this way, right? If you dig down a little further, here is one of our maps, and this actually has 4 school districts combined on it together in the Victoria area, divided now by neighborhoods with the same cutoffs. We've established these cutoffs that dark green is less than 16% and light green that color, so that people can look at the maps across the waves and they can look for green versus brown shifts, right? So it becomes easy color coded. And here, once again, we see the green to brown range. But the difference is that the brown range goes way, way up and the green range goes way, way down. So you can see here, there's one neighborhood that in fact has 53% of the kids vulnerable on it, right? And in fact, if you go across the province as a whole, 461 neighborhoods, 32 neighborhoods now with not enough children to report. And it's interesting, fertility rates have been dropping at the rate that when we started this work 10 years ago, we had 480 neighborhoods and virtually all of them had enough kids. And now we've combined neighborhoods down to 461, and even there, 32 of them don't have enough kids to report. Notwithstanding that, the range of vulnerability is from a low of 3% to a high of 61% in the last round, right? And every round, it's about like that. There's some places that are less than 5% and other places that are over 60 and even as much as 70%. So a huge variation. This is a 20-fold variation, right? And if you think back, and I didn't make a big point of this, but if you ask how big should our gradients usually when you look at different factors, they're not usually that big for most things. So if you look at gradients of, let's say, infant mortality in this province, they're nothing like 20-fold from one place to another, or under 5 mortality or things like that. Usually speaking, if you group things into, say, quintiles or something like that, you might get a 2 or 3 to 1 gradient, right? Now here, there's all sorts of aggregation issues, but the point is that the level of difference from neighborhood to neighborhood across this province and across Canada, because we have a pan-Canadian platform, in terms of the state of children's development, based on, these cutoffs for vulnerability are not high. I mean, we're talking about calling a kid vulnerable on the language and cognitive if they don't know any letter or number facts. We're talking about calling a kid vulnerable on the emotional scale if they initiate fights all the time. On the communication skills if they cannot tell you what they did yesterday. So these are not a high threshold, right? And yet, we're emerging with these 20-fold differences in the level of vulnerability from the highest to the lowest across neighborhoods in British Columbia and across neighborhoods in Canada. And yet, we do get some that, you can see in this last time out, 21 neighborhoods were under 15%. And in fact, over the 4 waves of data that we've done so far, a full 1/4 of the neighborhoods in BC have at least at one time or another been under 15%, right? So we're starting to be able to say, based on that and based on a number of other things, that under 15% is feasible, under 10% is possible. And so all across the province, where about 30% of the kids are vulnerable, we're sort of saying that about 2/3 of the vulnerability is potentially avoidable, right? And then you can see the numbers that are higher than that. So the maps reveal large local area differences in the proportion of developmentally vulnerable children. The high proportion of avoidable vulnerability, and this idea that if we use 10% as a cutoff, that you can say then, what the levels of excess vulnerability are, is a kind of a touchstone for that. And so the 10% figure is based on, across Canada, seeing in practice both wealthy and not wealthy, urban and rural, racially or ethnically diverse and ethnically not diverse neighborhoods all represented one point or another in under 10%, right? So it's sort of like a standard thing that if places have reached it, it is reachable, right? So if Finland can have an infant mortality rate of 2.3 per thousand, then Canada can too, even though it's stuck at about 5, right? It's like that kind of idea, right? That the best that has been measured is possible, right? So based on that, we can say in BC right now, where we're standing at 30.9% of the kids vulnerable, that about 2/3 of the vulnerability is excess, and that even in places like the North Shore, where vulnerability rates are sitting at about 20%, probably half of that is excess. The degree to which socioeconomic context explains and does not explain variations in early development. So we have created, using census data and tax filer data, profiles of each of the neighborhoods in the province according to socioeconomic status, right? So these are an ecological measure of socioeconomic status, and with all of the issues that those of you who've taken EPI courses know about. But notwithstanding that, if you take each of our 400 and whatever neighborhoods as a data point and you regress them against our socioeconomic best fit model, about 50% of the neighborhood to neighborhood variation is explained statistically based on socioeconomic factors. So that would be the income characteristics, economic, education characteristics, residential transiency, et cetera, factors like that, right? But that leaves another 50% that is not explained, right? And we've been doing an awful lot of work to understand where that comes from. So we call those the off-diagonals, the places that do better or worse than you'd predict based on socioeconomic status. And we're looking particularly now at whether or not social capital, in other words, things about social trust and participation and institutional affiliation and things like that might have to do with that, right? Which is work which is going to be reported on this year. So that leads to the fourth point here, which is which communities are doing better or worse than predicted based on socioeconomic status to set up the study of why. And then to be able to trace change over time and to serve as a rationale for programs and policies. Now, the change over time story has not been a good one. Basically, vulnerability in BC has gradually snaked up over the last 10 years. So when we first started measuring this, it was sort of like standing at about like 27% and then 29% and then 28% and then 31%. So, you know, if anything, it's gotten worse, right? I mean, because of the non-random error that exists in this system, we use for the province as a whole a 3% difference as a meaningful difference for the province as a whole. And so over the last 3 waves, it's been about 3%. So where the politically careful way of saying it is that there's been no net progress. But really, if you look at the data, there's been more bad news stories than good news stories. But there have been good news stories, right? So if you go down to the neighborhood level, here is Nanaimo, right? And so what you've got here this way is the overall level of vulnerability on wave 1 of the data in the background in all of the neighborhoods here. And then in the foreground, what you've got is the relative contribution of each of the 5 scales of the EDI to vulnerability. Because it's vulnerability on one or more, it's not linear, right? It's sort of as soon as you're vulnerable on one, you're vulnerable, right? That's the way this goes. But you can see the way that goes. So if we gray out the irrelevant place, and we just look at this area of Westwood, right? There is an area that was light brown on wave 1, vulnerability in that range there, 27 to 34%, basically, right? We look at wave 2, it's dropped into the yellow, so it's now in the 23 to 27%. You probably saw some of those pie slices coming in. And then by wave 3, it's into the green, so it's down into this range here. And some of the pie slices, particularly the physical and emotional, have come in even a bit more, even though the communication skills, probably in this case as a result of in-migration, has gotten a bit more challenging. So we have a number of these kind of places around the province where there has been monotonic improvement over time, right? So as you can imagine, we're interested both in the positive off-diagonals, the places that are less vulnerable than you'd predict based on socioeconomic status, but we're also interested in the trend buckers. In other words, the places where the state of early development has been getting better, despite the overall pattern in the province, which has been getting moderately worse. So I'd like to talk a bit about the characteristics of this, but just to go back to this question about why things would be getting moderately worse over time. You have to understand a few things about Canada. One, Canada is the lowest investor in the Western world in the early years in terms of things that are analogous to school, right? In terms of doing things to support children's development other than traditional medical care, right? So we spend 0.3% of our GDP on development in the early years, right? 0.3%. The average in the European Union is 1%. And the Scandinavian countries, it's about 1.5%. So unlike many other areas where we're on the flat of the curve, let's say with medical expenditures per capita as a proportion of GDP, we're not on the steep of the curve. That this is an area where you get what you pay for, right? So those societies that have systems, policies to make it statistically impossible to have little kids and be poor, that have universal access to quality child care programs, that have kind of maternal care programs that actually go out and find all the families and don't just accept the fact that 30% of the families never show up, that have workplace flexibility leave programs to deal with work-life, home-life conflict, et cetera, they get what they pay for. Whereas what's been going on in Canada is we've had virtually no positive movement with family poverty. We have the lowest level of access to quality childcare in the Western world, and despite all the politically inspired nonsense. If you look at socioeconomic gradients among kids who have access to licensed regulated care, they are flatter than for kids who do not have access. In other words, kids in lower socioeconomic groups benefit disproportionately from access to that, right? And also, in Canada, because of the way in which the globalization of the economy has been going, over the last 10 or 15 years, the number of hours that parents have to work to maintain a given socioeconomic level has been going up. So between 1996 and 2006, it went up by 300 hours a year. And those are 300-hour family hours. Those are not between 2 and 4 a.m., typically speaking. Those are in the morning at dinner time. That affects bedtime stories, right? It affects sitting on lap time, right? So what's happened is that those pressures exist all across the Western world, that Canada historically had a weak system, and in this current period has not managed to get anywhere. And to be overtly large P political, the federal government under the Liberals started a federal provincial transfer analogous to Medicare against what they called the Quad Principles back in 2006, and then they were voted out of office. And the first thing the Conservatives did when they came into power is cancel the transfers, right? And they went with a model of all families for themselves. So we'll give you $100 a month baby bonus and you work it out yourself, right? So it's a big story. But the point is there are reasons then that the pressures have been downward in terms of development. And it's a little bit of a time bomb, not unlike our ecological footprint. However, notwithstanding the macro picture, when you go down to the micro picture, we have learned some things about the places that are doing well, right? And these lessons are interesting because they're transferable regardless of the argy-barger at the higher political levels, right? So, for instance, intersectoral leadership. One of the things that was done well in BC is that there has been funding available either through the United Way or directly through the Ministry of Children and Family Development to have intersectoral coalitions for early child development. And that's important because if you can imagine that what you're trying to do is optimize the opportunity for physical, social, emotional, language, and cognitive development, that there's a lot of different players involved with that. Childcare people are involved with that, recreation people, family support people, municipal planning, the health authorities, et cetera, et cetera. So that if you can put together a coalition of those groups and include also the economic sector and be pushing for better workplace flexibility programs, et cetera, you can have some real strength. And what we've seen is that in the communities that have strong, stable intersectoral leadership, working together in coalition at the highest levels, that they seem to be able to make progress in early childhood, even in an era when the macroeconomic and social and political forces are more hostile. So that's an interesting lesson. Focus on the EDI outcomes. One of the things that we've been doing is producing toolkits and going out to communities and teaching people how to look at the EDI outcomes and how to think about what the community is like in relation to each of those outcomes and where there might be barriers of access, et cetera, et cetera. So those communities that have actually used the EDI data, so that when they get together in an intersectoral table, they're talking about physical development, they're talking about social and emotional development, they're talking about language and cognitive development, and they're not simply talking about organizational jealousies and all that sort of thing. That seems to make a difference. So that this idea of trying to change the way in which non-traditional actors from a health standpoint use data and use outcome-oriented data and focus their efforts to move the outcomes rather than focusing their efforts to advance their organization's interests does seem to make a difference. Next thing is, I mentioned a bit this before, but we're really interested in this idea of barriers to access, right? And so we've done a lot of work based on hearsay and literature reviews and mini studies in one way or another to try to figure out, right, if here's a child here from the perspective of a child who could use an experience to support their development, what are the things that stand in the way between this child and that thing, right? And so at one level it could be that the thing doesn't exist, or that it costs too much, or that it's offered at the wrong time of day, or that it's offered in the wrong language, or that the parents don't trust the providers, or that the parents don't know that the thing exists. So we have a list of 10 things that we go with. And of course, what we've seen then is those communities that will take the list of barriers, the EDI outcomes and the programs and services and activities in the community, and ask, how do these things fit together? And they try to actually knock down the barriers that are actually existing, that you get benefits from that. And that requires a lot of local tacit knowledge to understand, we've posted the Mum and Tots program in the local laundromat, but the women who are coming into the local laundromat, are coming from an ethnic group where they do not trust the service providers. So we have to do something about that, right? Unless we have an Aboriginal worker, they're not going to come. That kind of thing, right? So that matters. Vertical coordination. What we've discovered is that it is not a question that communities either go it alone or wait for senior tax dollars to fall on them. That what happens is that communities that are fairly well organized and mobilized at the local level are better, not worse, at attracting senior government dollars. They are quicker to find out about programs, they are better at lobbying, and they keep the money. And in fact, for those of you who looked at that provincial map, you will have noticed that the two greenish areas in the province were, one, the sort of wealthy areas on the North Shore, but two, that area in the Kootenays, right? And one of the things that's going on in the Kootenays is that any area which is part of the Columbia drainage basin, the drainage basin of the Columbia River, qualifies for money from the Columbia Basin Trust, which was set up years ago when they dammed the river and destroyed the salmon fishery up there, right? So over the years, that fund has been building up and up. And so it's like an alternate source of revenue to build social infrastructure. And the Columbia Basin Trust is organized so that you can't get the money unless you work together. So if you're, let's say, in Nelson, and you go yourself to try to get money for some program, and you are not doing it shared with all the other programs, they won't give it to you. It has to come together, right? So they have an alternate source of money that is not sensitive to federal provincial politics so much and is organized to incent intersectoral activity. And as a result of that, you find in some of these areas that people like the school superintendents working in coalition with other people are really seen as community leaders and people that can bring resources to the community. You go to a place like Revelstoke and you can see these things functioning in a way that's hard to imagine in a place like BC. And so what it shows you is that, up to a point, not so much for social and emotional, but for physical, language, and cognitive, privileged communities can buy their way out to a certain extent. But otherwise, it's about community process. It's about these kind of things, right? Finally, alignment with the school system. I'm a big supporter, both of the Strong Start program, which is a family support program that's situated in schools that is now in about 350 elementary schools in the province, and also the expansion of full day K using a play-based program rather than using a schoolified program. Because what we've seen is that the school system has the cachet of universal access. The schools are local. The schools have a local mandate. They are taken seriously, right? One of the problems in terms of early child development in all of the English-speaking countries has been an ideology, and it's a deep-seated ideology that goes back to the Elizabethan Poor Laws of 1620, is the notion that families should take care of themselves, right? And that if there are challenges within the family, that the approach of the state ought to be punitive. In other words, it's not it takes a village to raise a child. It's the opposite. It's if the village needs to raise the child, we'll probably take the child and we'll probably punish it, right? And that's where the poor houses came from and all the rest of it. And even though we don't still operate that way, that is what's inside of a lot of people's heads, that somehow or another, this idea that magically, when kids turn 6, they are ready for school, and therefore the state will organize the school system. But before that, you're on their own, and we're only going to go in if there's a problem, right? As opposed to saying, kids are developing from the beginning. How can we support it together? So what happens is, though, when you build the system up around the schools, people think of schools as universal access as opposed to social work, right? And that destigmatizes the whole idea of supporting development. And so this co-location thing is very important. And really, at these days, Ontario is doing the most with this, and they're doing it notwithstanding the fact that they've got deficit problems that we don't have. And it's going great guns. And it's very interesting to see that when you bring the cachet of the school into the system, that all sorts of people who will not show up to traditional middle-class programs or whatever will show up. Aboriginal kids in the inner city and so forth, right? Boy, I'm taking a lot of I'm just going to keep hitting ideas, okay, just to kind of fill you up with a bunch of things. One of the things that we're doing here is using the facility that we've got on the second floor here, Population Data BC, to link the EDI data to school data and to start actually creating population-based developmental trajectories. Our vision is to start at birth and link birth and health data to our kindergarten data to school data and through to graduation to actually create kind of normative developmental trajectories. But for the moment, what we've done is we've linked the EDI scores to the standardized reading and numeracy tests that are done at grade 4. So this is the first full wave of kids in BC, about 40,000 in all, looking from kindergarten to grade 4. So the zeros are the kids who are not vulnerable on any scale of the EDI in kindergarten. The 1, they were vulnerable in 1 out of 5 scales, 2 out of 5, 3 out of 5, 4 out of 5, and all 5. Then up here, fast forward 4 years based on an individual linkage of their data, but then anonymized, so we don't know who they are. You can see what proportion of them did not pass the reading test in grade 4 or the numeracy test. And what you basically see is a monotonic increase in the fraction of kids who do not pass as you go up the number of vulnerabilities. So 0 vulnerability, about 20% didn't pass. 1 vulnerability, 35. 2, 45. 3, 55 to 64. 65 to 75, over 80%. Right? So it's interesting, right? Because what this is showing then is that what's happened up until the time kids reach school age is influencing and challenging what's coming afterwards. And in fact, one of the things that we're engaged in now is a bit of a shadow war with the Fraser Institute, because the Fraser Institute publishes these school scores raw and claims that the schools that have low failure rates are the good schools and the ones that have high failure rates are the bad schools. And it is insidious, ideologically driven statistical malpractice, right? Because it's designed to make the private schools look better than the public schools, basically. That's what they're trying to do. They're trying to undermine the public system by doing that. What happens is, if you adjust the scores by EDI vulnerability and by socioeconomic status of the catchment of the school, about 50% of the school-to-school variation is explained, and then you can see which schools are doing better or worse than you'd predict based on EDI and SES. And when you do that, what you find is that most of the private schools and most of the public schools in upper middle class neighborhoods are doing just about as you would predict. And then when you go, say in Vancouver, from the southwest part of town into the north central part of town, what you see is this huge splaying out. So you'll have one school where the fraction of kids who don't pass the FSAs will be about 20% higher than you would have predicted, side by side with a school where it's about 20% lower, right? So there you've got a pair of schools where one school is doing amazingly well and the other school is collapsing. And rather than those schools forming a group to learn from each other, this other thing is being done, right? So it's completely distorted what's going on. But the other thing, too, though, is that when you start putting these data together, what you can see is the economic returns from investment in the early years. So we've been able to model this out, linking EDI to grade 4 data, and then separately grade 4 to school graduation, and then gluing them together. It's sort of a synthetic cohort approach. You can say that, where vulnerability stands at 29%, like it did for a couple of waves ago, that predicts about 41% of the kids will come out 12 years later with university-eligible grades as an index of the competencies they've acquired. So I'm not saying everybody's got to go to university, but it's an index of their competencies and their capacity to go on for further education. If we drop vulnerability to 15%, that would go up to about 50%. And if we drop vulnerability to 10%, that would go up to about 56%. In other words, there would be a 34% increase in university-eligible grades. And this is important because these days about 70% of the new jobs that are coming into society require that level of high school leaving, right? So that right now we're 40% are reaching the level, the economy is demanding 70%, and if we reduced EDI vulnerability, we could make up about half of the difference. Now, we've now then gone ahead and modeled what the returns to the economy are with this. And to make a long story short, by having vulnerability sitting in the 30% range rather than the 10% range, it is as though we are throwing away $401 billion in current dollars invested at good market rates, not current, like sort of 3 to 5% over the next 60 years, right? So it's like a big effect, right? So it works out that for every dollar we might spend to effectively bring vulnerability from 30 down to 10%, we would get about $6 return in the economy, even discounted for inflation, right? So this is based on Canadian data. This is not based on randomized control trials of ghetto communities in the States or something. This is based on here. We also have this other interesting thing where, approximately 30% of the kids are vulnerable. Most vulnerable children are not poor, so there's a difficulty with targeting. One of the problems we always get into is the old debate about targeting versus universality. For those of you who get into this field, you'll discover that targeting universality is like nature versus nurture, right? And as has been said before, when, I can't remember who the guy was, it was one of those Nobel Prize winners, was confronted with the nature versus nurture. His answer to that was, what determines how big a rectangle is? Its length or its width, right? And that's what nature versus nurture, and that's what universe versus targeting is that you're pulling things apart ineffectively. So to think about what gradients mean, if you think about going from communities that are relatively advantaged to relatively disadvantaged, what you see is that gradually the fraction of vulnerable kids goes up, right, as we would expect. So that the proportion of children here who are vulnerable is much higher than at that end. However, when you look at where the population is mostly in here. So the number of vulnerable kids is greatest, spread relatively thinly across the broad middle class, right? So take an example like, let's think. So if what we want to do as a society is take a system like this, and this is now neighborhood data points from the most advantaged to the most disadvantaged, showing vulnerability going up in a scatter, so we've got the positives and the negative off diagonals there. What we would maybe want to try to do is come up with a series of policies, interventions, social changes of one sort or another that would sort of do that, would flatten the gradient down, right? So, let's look at Vancouver, right? Here's Vancouver divided into its 23 neighborhoods, right? And the socioeconomic status of the neighborhoods are shown from green to red here. And so you can see the relatively wealthy neighborhoods and the lower socioeconomic neighborhoods. In each of the neighborhoods, there are these little homunculi, and each one represents numerically 5 vulnerable kids off of a wave of EDI. So you can see what the absolute distribution of vulnerable kids is like around town. You notice part of the reason that there are fewer numbers out here is because the numbers of kids 0 to 5 on the west side is much smaller than it is on the east side because of housing affordability, basically. So if what you do is you want to go for targeting, in this case we'll consider geographic targeting, what you might get would be something like that, right? You hit the low socioeconomic neighborhoods, which are relatively high in vulnerability, and if it's effective, you would get something like that, right? The problem being, though, that the majority of vulnerable children would receive no benefit. So, like, if you go to Vancouver, the 4 lowest socioeconomic neighborhoods are these ones: Mount Pleasant, Strathcona, Downtown East Side, Grandview, Woodlands, and West End. And you can see these are the vulnerable kids who might get picked up in programs that are based in those areas. But look at all of the vulnerable kids elsewhere that are not picked up. Right? One of the things about having population-based, geographic-based data like this is that you can actually show that no targeting that anybody can conceive of, be it geographic, be it family risk scores, be it biological things like low birth weight, et cetera, is ever going to pick up more than about 15 or 20% of the vulnerable kids in any community. Right? So you can see that targeting by itself cannot work to shift norms. Right? On the other hand, the usual problem with universal programs is that when people talk about universal programs, that means a program that is open to all. So the public library, the story hour at the public library is a universal program. It doesn't mean that everybody's going, but it means that everybody can come. Nobody will be turned away, right? When you have programs like that, and many of our health programs are like that, then what you can imagine is if you go back to the barriers of access that I was talking about before, as you go from this end of the spectrum to that end of the spectrum, the number and complexity of barriers of access from the standpoint of the child getting access to the program goes up. So at this end, we know the principal barrier of access is time, right? Parents are busy. Both parents are working, right? Programs are not offered when parents can get the kids there. There's an issue, right? As you go down the socioeconomic spectrum, cost, transportation, language, information, social trust, all of those things start to build up, right? So, if all you do is organize a program and throw open the doors, the expectation, and it works, the expectation is that it will work, but it'll steepen the gradient. Because there will be differential access, and there will be higher access at this end, right? Now that is a net improvement, but it is also an increase in inequality, right? Theoretically, that's what would happen. And so, the kind of idea that has emerged from the WHO Commission on the Social Determinant of Health is this notion of proportionate universality. That is to say, universal access at a scale and an intensity that addresses barriers at every level, right? So, universal access, in other words, programs open to all, but organized in ways, by neighborhood, by whatever, whereby the barriers of access are addressed so that the intensity differences exist, right? With the idea that what we are hoping to do is that, right? That would be the idea. And so that is what we're talking about these days, is proportionate universality and barriers, as opposed to the old saw of targeted versus universality, right? And trying to get this idea out there as a way to go. Now, with this, of course, the investments, the difference between spending 0.3% of your GDP and spending 1.5% of your GDP on the early years is huge, right? And even in the most optimistic times, it's not easy to get society to think about that, and even with the BC Business Council and other business groups buying into our returns on investment models, it is difficult. But one thing that we are saying is that because we've created this early development indicator system and this approach to population-based developmental trajectories, we've got the outcome information. So that what we're suggesting is that we find ways to invest and measure and invest and measure, and invest in the things that move the indicators. So it's like outcome-oriented social change kind of model, right, is the kind of thing we're proposing. Okay. That gives you an idea of how we've started with notional social determinants of health, the contribution of the early years, the measuring and the embedding in society of a process of trying to address that. Now let's turn around and go back to those characteristics of the gradient, the disease independence, the replication on new conditions, etc., etc. This requires an understanding of the developmental biology of the gradient. And in particular, it comes down to an hypothesis that we generated, and I have to say I generated, about 12 or 13 years ago, called biological embedding. Biological embedding is said to occur when experience, as the metaphor goes, gets under the skin and actually alters human biodevelopment, right? And does so in stable long-term ways. So we're not just talking about when you're under stress you function differently. We're talking about things that actually change circuitry and change the biological rules of organization, such that systematic differences in experience in different social environments lead to systematically different biodevelopmental states. And that the differences are stable and long-term, such that they can be shown to influence health, well-being, learning, and behavior over the life course. In other words, based on the character of the gradient, back in the 1990s, we came up with a hypothesis that biological embedding must exist, right? Based entirely on the pattern of human data. What's been going on over the last 15 years or so is that a whole bunch of different interdisciplinary groups have been digging away at this question and trying to understand what's going on. And so one of the things that we've gotten very interested in is what we're calling the archaeology of biological embedding. Trying to understand, okay, how does experience influence, measurable things like behavior and development? How does that relate to the function of, let's say, neurocircuitry? What does that mean at the level of the cell? And what does that mean at the level of the gene? So like digging down to try to understand this, right? And so the way I've been spinning this is to talk, first of all, about a kind of a shallow archaeology. In other words, what is going on at the level of the systems that have been called the transduction systems. In other words, the systems that are designed to relate between you and society, right? And so the hypothalamic pituitary adrenal axis, right? which is one of the systems that deals with stress and cortisol. So there's a lot of work out there looking at how that axis and the expression of cortisol can be conditioned by experience and can change its function over the life course as a result of experience. Same with the autonomic nervous system and epinephrine, right? So there's a lot of work there. And some of the best work has been done here in BC and in San Francisco, etc. Third, the prefrontal cortex. So this is the executive function system, right? And we do see that by age 3 or 4, the executive function systems do function differently according to the quality of early nurtured environments, right? So that issue, right? The social affiliation systems of the amygdala and locus coeruleus, which we talked about before. And then finally, the immune functions, which serves as a kind of peripheral brain. And we're really learning now how the immune system and the brain speak to each other, right? So there's a lot of work going on at that level. And just one example, for instance, is some work we did up in Kamloops, where we went into a high socioeconomic, low EDI vulnerability area on diagonal, and a low socioeconomic high vulnerability area. So these were on diagonals, typical. We got groups of kids, put the ERP shower cap on them, and then got them to do memory and attention tasks, right? And the difference on average between these two groups is the existence of this notch here versus there. So this notch here, I'm not going to go into the details of it, but basically it shows that the kids from this area here had an easy time mounting a focused attention, because this is a subtraction wave from this to this, right? So the task was before them, and they were able to push out the irrelevant stimuli and focus on the stimuli of interest. These kids over here, no notch, right? Now, we're not the only ones who have shown this. A number of groups have now shown that by, say, age 3 or 4. Kids who are growing up in unpredictable, chaotic, threatening environments start to show systematic differences in these kind of prefrontal cortex activities according to the quality of the nurturant experience that they've been in. And the good news is that when you get it at age 3 or 4, you can change it, right? So there are programs that have come out of Oregon, and here Adele Diamond is working on these things and trying to get, the system to understand that we can create focused attention in the kids if you deal with what we understand about the process of biological embedding, and we get it at the right time. So at the level of shallow archaeology, there's all of this kind of thing going on. However, we now have something else that we're calling deep archaeology, which has got to do with social epigenesis and other processes that can influence gene expression. And so I'd like to take a minute on this idea of influencing gene expression, right? Here are two butterflies. You notice the one on the right is larger than the one on the left. It is a different color than the one on the left. Not only is it wings, but its body are bigger than the one on the left. These two butterflies both live in the same environment in sub-Saharan Africa. This one here on the left flits around being delightful, and this one here basically, sits in the dark and doesn't do much, right? And so what? Two different butterflies. The so what is this? These butterflies are the same butterfly. Genetically identical. Just that one there was in the cocoon during the wet season, and this one here was in the dry season, right? Same genes, completely different phenotype, right? So this is about epigenesis. In other words, it is about the processes that can influence the way in which genes express themselves and can continue to influence the way that genes express themselves even as cells divide across the life course, right? And we now understand that there is a whole series of different epigenetic mechanisms, so that you have one genome, but you have potentially many epigenomes, right? The interest in this started to become acute when the genome was completely read, and it turned out, lo and behold, we only have about 24,000 distinct genes. Everybody was thinking there were hundreds of thousands. 24,000? I mean, that means we only differ from the chimps by, 500 genes? Is that enough to explain the difference, right? There's got to be more to it, right? So this issue of epigenetic mechanisms started to emerge at that point. One of the ones that's been best studied is called methylation of the DNA. And methylation is simply where a little methyl group, that's a carbon with 3 hydrogens, plops on to one of the 4 DNA building blocks, a thing called cytosine. You all know probably adenine, thymine, cytosine, guanine, the 4 building blocks. So you methylate a cytosine, right? And some metabolic processes will methylate a cytosine. And what that'll mean is, let's say if you methylate a cytosine in a region that is designed to turn on or turn off a stretch of DNA, and the messenger RNA comes along, and the methylation is there, so it changes the structure of the DNA. It can't read through it. It downregulates the gene. Right? That's basically the kind of idea that you get. Right? So methylation, among all of the different potential mechanisms of epigenesis, is the best studied as it stands right now. And what's new about it is, we always understood that there had to be mechanisms that turned on and off different stretches of the DNA. After all, your skin cells, your brain cells, all your cells have the same DNA, but they're all different, right? And so what was assumed is that during fetal development, there were mechanisms that turned on and off different stretches of the DNA, but then it was fixed. What we understand now, though, is that it can and it does continue after birth, and it can be influenced by the broader environment. So although the greatest intensity of epigenetic work is occurring when cells are differentiating, the process continues thereafter, right? And epigenesis becomes a way in which the physical, the nutritional, the social environment can speak to the DNA and change who you are, right? There's wonderful work in rats showing where you take rat babies and you cross-foster them from between high and low licking and suckling rat mummies, that the rats who have the high licking and suckling mummies, that licking and suckling sets about a biochemical cascade which methylates and demethylates different stretches of DNA, which end up down-regulating the hypothalamic pituitary adrenal axis. So high cross-fostering to remove pure genetic effects, high licking and suckling during day 9 to 16, critical window of development, down-regulation of the HPA axis through methylation, meaning better functioning HPA axis throughout the life course, less aging of learning and memory cells, so that when you take these rats that have been high-licked and suckled and you throw them into a vat of murky water at 2 years of age, which they don't like, and you see how long it takes them to swim out, the ones that have been high-licked and suckled can get out much faster than the ones that are low-licked and suckled. As the life course goes on, it increases because their cumulative exposure to cortisol in the learning and memory centers is lower, less brain death, etc., etc. Also, if you were a female born to a low-licking and suckling mother, and cross-fostered to a high-licking and suckling mother, when you become a rat mummy, you become a high-licker and suckler, and vice versa, right? So intergenerational transmission, right? A beautiful model of biological embedding of early experience during a sensitive period in development. Monkeys. It's a lot more difficult to get at these kind of things in monkeys, but the monkey colony, the National Institute of Child Health and Development monkey colony in Maryland, did sacrifice small groups of monkeys who were mother-reared versus peer-reared, and sent their prefrontal cortexes to Montreal to look at gene differential methylation in the prefrontal cortex of those monkeys that were raised by their mothers versus all just put in a group together and given a doll, right? Basically peer-reared, right? Long story short, 4,000 out of 20,000 genes differentially methylated, according to mother-reared versus peer-reared, right? This is the prefrontal cortex. Now, there's a funny, for anti-vivisectionists, none of this is funny, and I must say, cutting up monkeys makes me nervous myself, but amygdalas were also removed and sent, but they were lost somewhere in the mail. So if one day you receive a package that says monkey amygdalas, let me know and I'll tell you who to send them to. Anyway, those are rats and monkeys. Humans. Epigenetics in humans. There's been interest in terms of stress, nutrition, and lifestyle. There's been interest in twins and the divergence of twins across the life course, and there's been interest in terms of maternal care and how these things work. And so, to be honest with you, the work that we've been basing at the Human Early Learning Partnership and through the Experience-Based Brain and Biological Development Program in the Canadian Institute of Advanced Research is some of the most advanced with this, because we can put the interdisciplinary teams together. And so we've been interested in taking populations that are part of Lifecourse studies and collecting blood and buccal samples, in teenage and in middle age, and then looking backwards at the early life determinants in relation to this. And there are 2 studies right now just to draw your attention to. The first comes from that 1958 British birth cohort. So we're looking at red blood cells epigenesis at age 45, right? And what we found, to make a long story short, is 1,252 genes differentially expressed according to socioeconomic status at age 0 to 7. So this is going right back to where we started from. So when you compare those who are high socioeconomic status from 0 to 7 versus low, 1,252 differentially methylated genes, meaning differential expression of one sort or another, 6% of the genome. Way upstream, all sorts of things having to do with genes that code for how the brain develops and all that sort of thing, right? So making sense of it biologically is still emerging, right? But it's about the plasticity, right? The other piece, for those of you who read the newspaper over the last week or so, you will have seen the second one, which is data, the longitudinal studies in Wisconsin, but the analysis was done here in Vancouver. So we're looking at buccal samples of kids at age 15. You think, buccal samples, what good are they? Well, buccal samples are the same germ layer as neurons, right? So actually, this is a big argument. How do you find things that stand in for the brain? So the buccal, turns out, isn't a bad surrogate either, right? Anyway, to make a long story short, what we found there is, based on the true prospective collection of what parents were saying, and this is a study where they were following kids every few months, so they have like 0, 6, 9, 12, 15, 18 months. So in the cumulative stress that mothers experienced and reported, financial, social, etc., in the first 18 months of life, left epigenetic marks on 139 different genes, right? Not fathers during that period of time, mothers. Although when you look at father stress closer to school age, then it starts to emerge instead. So we get quite interesting specific patterns here. And these are both now based on methods of doing lots of genes. Like in the British birth cohort one, it's basically a method, expensive method, allows you to look at all 20,000+ genes. This method here it allows you to sample the cytosines. So we have a sample of cytosines. So you get a smaller mark, but nonetheless an interesting specific mark that loads on mother's stress and not on other things and so forth. So the point of all of this is that we're at the point now of starting to understand how biological embedding works, and that a lot of it does come down to the ways in which nurturant experience can speak to the genome and can change who we are based on that, right? So the metaphor that went into the newspaper is, rather than thinking about the DNA having a one-way conversation with the environment, we're now talking about a two-way conversation, right? And from this then, hopefully, rather than scaring parents, we can use these studies to understand the developmental biology of daily life and understand what kind of guides to social development we need to get from this. And this is really then, if you'd like, the basis of the notion of equity from the start. And I'm putting up here then a cover of the WHO report on the Commission of Social Determinants of Health, for which equity from the start, which has to do with these things, was one of the chapters, and suggest that this might make very good reading for you. And with that, I'm going to shut up, which I'm sure you'll be very happy with. Thanks for listening.
Hi, thank you so much.
Yeah.
Would you mind if we have a few moments for questions?
Not at all. Not at all.
Please, questions, points of clarification. There's a lot of material. Many of the highlights that Clyde drew attention to we'll come back to during our course time and time again. But if you do have questions that you want to ask Clyde now, please. Just introduce yourself while you do that.
My name is Katie Muldoon. I'm a second-year PhD in the program.
Right.
Thank you so much for this fascinating. When you said that kids who grow up in chaotic environments, they have these risk factors less likely to focus. What if the entire community goes through a chaotic environment, or there's like this entire province, or areas in like different countries that have been having prolonged exposure to chaos,
Mm-hmm.
and you can't just go in and do like these, like identifying these kids who
Yes.
could benefit from interventions, but
Oh, yeah.
what do you do when it's been mass experience?
That's a very good question. I mean, in a certain way, part of the answer to that, like you take Bosnia, for example. One of the things that we know is that when stuff like that happens, and this is not like, when you have, let's say a hurricane strikes and the community pulls together, that can quite often actually be a benefit, right? Like, in fact, even World War II, you see socioeconomic gradients shrinking during war when everybody is all hands are on deck. But when you have the kind of thing of Bosnia or Katrina or something like that, where the externally imposed event basically shatters the community, by and large, what ends up happening is that about 30% of the kids, for some reason or another, tend to do better as a result of it, right? Like, and this has got to do with some sort of variability. It's a sort of a kind of resilience phenomenon. But with the other 70%, you have the problem that you've got a road warrior society, right? Let's say in those kind of cases, right? So the thing about it is that, in situations like Bosnia and some of the others, there actually have been groups that have gone in and said, we can't just assume that after kids have grown up in these environments where they basically become feral, that all we have to do is reopen the school and everybody will go in and everything will be fine, right? Child soldiers, et cetera, et cetera. Like, once you become that, it's not easy to unwind, right? And a lot of it has got to do with trying actively to retrofit social and emotional developmental things, right? And the kind of models that show the most promise are the ones which assume provisionally that for some of the kids, the competencies that they haven't developed are latent one way or another, and that if you go back and you assume that these people, their social emotional development is like a 3-year-old's or something like that, and you try to pick it up from there, you can make some difference, right? What we have a huge paucity of, though, is the stuff that is really truly population-based intervention, right? And this is a huge struggle in so many different ways, right? I mean, we're interested here in norm shifting, right? And even in BC, because of the steady drip, drip, drip of daily life, if you look at the vulnerability patterns across BC, I mean, some of them are ugliest in the places where the economy is just gradually tailed off and the community is just gradually sunk into, a kind of a genteel poverty, right? And there's a lot of places in BC, particularly up the west coast, that are like that, The fishing's gone, the forestry's gone, many of the people are still there, the people, upwardly mobile people left, and the other people are behind, et cetera, and gradually things just kind of grind down, right? And the question is, how do you actually do things that help shift the whole community, right? And in terms of evidence on that score, we don't have a lot that's very good. In the UK, for instance, they've started these Sure Start programs, which are meant to be community-based interventions in areas of chronic deprivation, right? And what's come out of those programs, and has also come out of programs like this program, Better Beginnings program they started in Ontario, is that when you go in with a one-size-fits-all community-based program, on average, the results look quite modest. But then when you pick it apart, it turns out that the modest benefits usually consist of communities that have done great and communities that have done nothing, right? And when it comes down to that, communities that have done great versus the communities that have done nothing, it ends up having to do with whether or not the community have got the kind of leadership that we talked about earlier on. When we talked about the communities that got better on the EDI, whether or not there's organic leadership that is seen as being legitimate in the community that can engage in the program and make it work, or if what you've got is just different warring factions that hate each other, right? And over again, this same principle comes out, right? That these community-based interventions become a litmus test for the social rule book. And some places have got social rule books that can engage, and some don't. I mean, it's the same when you try to reduce cesarean sections in medical communities, and some communities where you've got a learning group and you get to the influentials and the influentials get to everybody else, then the C-section rates go down. In other communities, you get to one group and their C-section rates drop, but these people over here hate those people and their sections go up, right? So it happens like trying to explain in the U.S. why some Aboriginal communities have 10% unemployment and others have 90% unemployment, right? And so that issue, right, of how you can take community-level interventions, engage in a social rule book, find the places where it works, and then go back to the place where it didn't work and try something different, is a whole process of population-based operational approaches, which nobody really has ever had the data flows, the political will, and the stick-with-itness to really try, right? But we're in an era where that really matters now. I'm sorry. The next question I will answer shorter. Yes.
Can you introduce yourself? My name's Claire Gorman. I'm in the second year of the MPH program.
Excellent.
And between sort of the idea of critical areas of development and critical times, as well as the fact that this data is all population level and not like the individual indicator of child's well-being, or rather their development, how do you share the information that's coming out of the help without it frightening parents?
Well, first off, the data on EDI is on each individual child.
Yeah,
but we don't use it for diagnosis.
Right.
Yes. How do we do it without frightening the parents? Well, it's interesting. We've been at this about 10 years now, right? And I've done all sorts of presentations in all sorts of places, and you get a wide range of responses. We haven't seen, actually, that much parental fright, partly because we've kept away from the individual labeling. We've talked about the capacity for change over time, and we've avoided getting into strict determinist kind of arguments, right? If you say, what this is saying is that it's all over by age 5, then you create fear and reaction. But if you say, look, these frame some challenges, right? We've never had data like these before. This stuff has been going on all along, but now that we've got the data, we can see it. So now we can address it, right? Those tend to create more positive messages. It is true, that some neighborhoods have at first felt stigmatized. But a number of those neighborhoods, when they've got active in relation to this, that really takes away the stigma when people start to do things, right? Another thing that was thought was going to happen was this, that the real estate market would be influenced by this stuff. And it's interesting because in Australia, which has similar data to us, it has been. Here, it doesn't seem to be, right? I mean, my grandchildren live in, downtown East Side, and housing prices there are shooting up like crazy, right? So, it's not happening here. The capacity of leaders and parents and communities to be able to use these data is greater than we think. And sometimes what this stuff does, right, is that it taps into well springs of things that people sort of knew anyway and makes implicit knowledge explicit. In fact, a lot of social research is like that. It's sort of like you put it out there and people say, oh, that makes common sense, right? But what it does is if you hadn't showed the data and asked people what they think is going on, what you'll turn out is that common sense could predict about 5 or 6 things. And what these kind of data do is it shows of all of the common sense possibilities, what is the real sense, right? So I can tell you, quite frankly, when we first started the National Longitudinal Study of Children and Youth in Canada, the common sense, or at least the articulated view before we started was that we would have a dichotomy, that poor kids would look different from non-poor kids, that abused kids would look different from non-abused kids, that Aboriginal kids would look different from non-Aboriginal kids. So it would be a series of dichotomies, right? When we produced gradients that showed that the burden of developmental morbidity, if you'd like, was actually spread at a level of about 25% across the broad middle class, that was precisely the opposite of what the predicted view was. And yet, when you presented it to people who didn't know what the earlier predictions were, many of them would say, well, that makes sense. That's just common sense, right? So, common sense, it always matters whether it's post hoc or not, right? So far as that goes. Yeah.
I think we have time for one more question. Go ahead.
Yes.
My name is Derek Masser. I'm also a second year in the PhD program.
Okay.
I'm wondering, with epigenetic modifications, the strength of the patterning that you receive from your mother and the strength of the patterning that you would get from your environmental exposures, how much can you influence in terms of a child's environmental exposure as compared to what they get from their mums? How many generations of change would that take?
Yeah, excellent questions. First off, it turns out that, a lot of what is regulated epigenetically is the stuff that says this is a brain cell, this is a skin cell, right? So of the 24,000 genes in the human genome, there are probably about 7,000 or 8,000 that are open for potential modification through the social environment, right? Some of that will be, starting in the second trimester of pregnancy after cells differentiate, right? And some of it will be later on, right? From the work we've done so far, it does seem that a lot more is plastic in that way in early development than it is later. So like when we compare in the 58 cohort, adult SES versus childhood SES, the childhood SES blows the adult SES out of the water. So that's clear, right? Beyond that, we don't know yet, right? I mean, the thing you have to keep in mind is that methods to be able to do whole of genome studies are pretty new, right? The method that we used for the 58 cohort study, at the time we did the collections, cost £1,000 a sample, right? British pounds, so it's really expensive. We now, in Vancouver, have got a method that will probably cost about $200 a sample, so we're going up, right? And, over time, as we be able to do these things, we'll be able to get closer to that. But basically, if you think that there's probably a quarter to a third of the genome that is open for environmental manipulation, that would be the answer to that. In terms of if you get epigenetic changes, how would they change across generations, right? Excellent question. In other species, for instance, let's say you take the rats, right, and you do that cross-fostering thing. It takes about 3 to 5 generations for it to wear off, right? So that's a kind of an idea. And in fact, Aboriginal people are quite validated by that because, they've had these kind of rules of thumbs about, where, you've got these histories. You go up to the Nisga'a where people got these histories going back multiple generations, how many generations it takes for the attributes that they feel like they have to wash through and so forth, and how long wisdom goes, right? It sort of follows those things, right? So that seems to be true in those cases. On the human side, we don't know. The closest we've got so far is one of our collaborators on the 58 cohort, a guy named Marcus Pembry, has been doing studies that use the Swedish family records that go back into the mid-19th century. And it seems as though if you look at patterns of famine that children experienced in the 1850s and 1860s, that you can see epigenetic traces of those going out several generations. But of course, didn't have the direct sampling then, but you can say, okay, this is what the 0 to 12-year-old males experienced in 1850 to 1860 in northern Sweden compared to southern Sweden, and then you go out and you do epigenetic sampling of their great-great-grandchildren, and what does it look like? They think you can see traces in there. So there's some tantalizing speculations that, in fact, events can occur that can carry on through. And it'll be possible, for instance, one of the big ones that, is being studied here is the Dutch hunger winter of 1944-45. So it's a population not expecting to be hungry that suddenly is hungry as hell, and like all sorts of things have been followed up with that. So that will be a possibility to get at some of that stuff. But it's going to be very, very slow developing, that kind of thing. Okay. Well, hopefully you're a little overwhelmed, because that'll make the course worth it, right, to be able to fill things in.
Well, thanks again, Clyde. Fantastic as always. And if you get another chance to see Clyde speak, go.